Okay, hi everyone. Hi Aman. So I think I'm visible and audible. Let me check myself so that I can start with the quiz on orbit and lacrimal apparatus. Just wait a while. I'll just check. Yes, I think it's okay. Just let me know quickly. Anyone? Yeah, I think should be okay. Okay, so I'm ready to give the test in the same manner like you see if you have given the test like this. So there are 10 questions as usual of orbit and lacrimal apparatus. This is the second season topic wise test. The first question is, which important anatomical landmark differentiate preseptal from orbital cellulitis? So there are 5 stages of orbital cellulitis. First is preseptal, second is orbital cellulitis, third and fourth are abscess, subperiosteal abscess, intraorbital abscess, and the fifth is behind the apex there is cavernous sinus thrombosis. So first and second stage differentiating by a very important landmark which comes from the periosteum goes to the tarsus of the eyelid, that is orbital septum. That is why the preseptal and postseptal means orbital cellulitis. How do you differentiate? 3 important clinical features. Pain, redness, swelling of the eyelids is present only in preseptal, but 3 important clinical features. Any of the 3 features are present, it cannot be preseptal. Like if the infection goes into the orbit, it will cause proptosis, extraocular muscle nerves involvement, ophthalmoplegia, and decreased vision due to optic nerve involvement. So proptosis, ophthalmoplegia, decreased vision goes if they are present. It cannot be preseptal cellulitis. Either it is orbital cellulitis or third, fourth, fifth stage. Now, how to differentiate orbital cellulitis from abscess is a radiological question. Only radiological you can differentiate. In the CT scan or MRI, there will be diffuse involvement enhancement in the orbital cellulitis. Whether abscess, as the name suggests, it is a localized abscess, may be related to bone, may not be related to bone, subperiosteal intraorbital abscess. Whether it goes behind the apex, that is cavernous sinus thrombosis. Now, how do you know it's cavernous sinus thrombosis? In the clinical question, you look for loss of cheek sensations and the other side involvement, because cavernous sinus can go to the other side, infection can go to the other side, and in the other side, 6th nerve is the first to be involved, lateral rectus can be involved. So that can be also the question which can clinically help you to know which stage of orbital cellulitis is there. So that's the first question. Hi again everyone. The second question is a clinical picture of the left orbit. If you know, this is the frontal bone. Quickly, frontal bone, lesser wing of sphenoid. This is optic canal. In the roof, 2 bones. In the lateral wall, zygomatic bone and greater wing of sphenoid. This is superiorbital fissure. And the medial wall, 4 bones, M, maxillary, L, lacrimal, E, ethmoid, and one more, body of sphenoid, which is not seen. In the floor, there is PAZAMA, pajama, palatine, lacrimal, and maxillary. Now, this is optic canal. The mark structure is in the greater wing sphenoid. That is wrong. That is in the lesser wing. That is the answer. Signal passes through this. SOF is also seen in the picture. Yes, this is SOF. And the fourth option should be correct because annulosubsent encompasses the SOF and the optic canal. That's the second question. Easy one, but you should know what the bones of the orbit are there. Okay, so we have to resume the quiz. Fine, doesn't matter. Okay, now this is a child having bulging, and bulging of the eyelid is there. It's not orbit written of the eyeball. Bulging and swollen eyelids means edema of the eyelids is there with redness and discoloration in the surrounding skin. Means we don't know it's a preseptal or orbital. This was seen after insect bite. That's the most common cause of preseptal cellulitis because that is close to the skin. On examination, there was no proptosis I've given, no ophthalmoplegia, and the visual acuity is normal 6.6. Means it has to be, you should answer, preseptal or orbital. I'll wait for you to answer. Answer is R. This is not a class that I wait and watch. This is a quick revision. Okay, this is not a class on e-medicos or any face-to-face class, right? Answer is preseptal cellulitis. This is a quick revision. I can't linger around 30 minutes on these 10 questions. Answer is preseptal cellulitis. This is a revision, not a class, please. Now, dacryocystorhinostomy is to make an opening between the dacryo means lacrimal sac and the rhino means nose. It is indicated in all of the following except in lacrimals. You should know DCR is contraindicated in less than 4 years because orbit bones are not developed. In acute dacryocystitis and fibrosed lacrimal sac like lacrimal sac tumors, that is fibrosed, or in granulomatous conditions like TB, sarcoid, leprosy, DCR is contraindicated. In lacrimal sac tumors, that's the answer over here, DCT is done, dacrocystectomy. Now some people, students say, sir, chronic dacryocystitis means fibrosed lacrimal sac. Absolutely not. Chronic dacryocystitis is the important indication of DCR. Fistula, you don't do fistulectomy, you do DCR, and mucocele also. These are three important indications of DCR, but tumors is not an answer over here. Yeah, good. Now, many people have got this question wrong, even the good ones. Chronic nasolacrimal duct obstruction, which is not true. If you put a Jones dye, fluorescein dye over the eye, dye over the eye, dye डालो आंख में, cotton डालो नाक में. ये test है Jones dye test 1. The dye will reach the nose because there is the dye will not reach the nose. That is correct because there is a obstruction of the nasolacrimal duct. On Bowman probing, you put the probe into the puncta, then canaliculus, then common, then the sac, and there is obstruction below in the NLD. You will hit the bone. If you hit the bone, it's a hard stop. In canaliculus and common canaliculus, there is a soft stop. Now, some people ask us, normal लोगों में भी तो सर hard stop मिलेगा. हाँ, normal लोगों में मिलेगा hard stop. But novel लोगों में आप probing करोगे क्यों? करोगे क्या? कोई ऐसे जा रहा हो, आओ भाई आओ, तो मैं probing करते हैं, आंख में बड़ा मजा आता है. So of course, patient is complaining that there is a epiphora, watering of the eyes. Then we do all these tests. Normal also, the dye will reach the nose. The Bowman probing hard stop is felt. We don't do in normal. Now there is a test known as Roplas, regurgitation over pressure over lacrimal sac area. On pressure of the lacrimal sac area, mucus will regurgitate. Yes, because in NLD obstruction, there is a backflow and there is a water accumulated in the sac, which can be converted into mucus. That can only be possible in nasolacrimal duct obstruction, in acute as well as chronic. But in acute, you can't press over the lacrimal sac area. Why? Because there is a pain, redness, swelling over here. Now you will press, patient will have pain. So Bowman probing, this Roplas test is contraindicated in acute dacryocystitis. It is positive in chronic dacryocystitis or chronic NLD obstruction. It cannot be done in acute. Now people say, sir, acute में भी आएगा, mucus आएगा, दबा दो patient को, हाँ, यहाँ दबाओगे, आएगा नहीं वापस आपके पास. As a patient, redness, pain over eye, if you press over this area, it will not come back to you. Okay, so this is also the true statement. In chronic, in common canalicular obstruction, who can tell me it will regurgitate, yes or no? Answer is no, because in common canalicular obstruction, the water is not able to accumulate in the sac. If you know the anatomy, okay, anatomy नहीं बता सकता R, okay, this is not a class. That's why water is not accumulated. That's why mucus will not develop. So it is only possible in NLD obstruction. That is in chronic, of course, you do this test. Now, if you do a syringing from the lower puncta, the saline will not come into the nose. It will come out of the opposite puncta, but not clear saline, because some mucus will be accumulated in the sac. So turbid fluid will come from the opposite puncta. Now, of course, some people argue, sir, if mucus is not formed, then clear saline will come. But out of the 4 options, Aman, I hope you know what I'm saying this, because you got it wrong. Out of the 4 options, the best option to choose, which is wrong over here, is D. Others are absolutely true. This of course can be in early stage, saline will come, but in later stage, turbid material will come. Here I have not written it's early or late, but chronic means it is late. So that's why D option is the answer over here. All right. Now, कहाँ खड़े हो आप? You are sitting. Where are you standing? You're standing behind the patient or in front. सर पे खड़े हो जाओ उसके. Of course, you are looking from the foot end view. If you stand at the head end view, that is known as Nabziger's view. Okay, and the scientist Nabziger. But when you stand at the foot end view, it is worm view. Now, worm is not the name of any scientist. किसी बच्चे का नाम अपने बच्चे का नाम वर्म कीड़ा रखोगे क्या? नहीं ना, अच्छी बात नहीं होगी. क्या बोलेगा आगे जाके आपको? वर्म महादेवन, वर्म चोपड़ा, अच्छे लगेगा ऐसे. Worm, कीड़ा नीचे से आता है ना, foot से आता है. That's why worm view is foot end view. Now, this is for proptosis. You see, the right eye is protruding out. So this Nabziger's worm view or qualitative assessment of proptosis means bulging of the eye. It is useful as a home testing in thyroid because thyroid is the most common cause of unilateral bilateral proptosis. Now, some people say the pathology is an OD optic. Arey optic this nahi hai. They should give you full forms. OD full form nahi. OD means right eye. You should know this. They sometimes write OD as right eye. OS means left eye. You should know this. Full form is not asked over here. Ocular distress, ocular sinister, and OU means ocular uterque. But you should know OD is right eye. OD is not optic disc over here. Yes, pathology is in the right eye. You see the right eye is bulging. Now, useful in myasthenia? No, absolutely not, because myasthenia, there is no proptosis. There is no pain, proptosis, pain in myasthenia. There is ptosis. Most common eye manifestation is ptosis. Then, observer is at the foot end, of course, that is worm's eye view. Quiz resume kar lete hain. Seventh question. A patient of neurofibromatosis, either 1 or 2. Very important question. Skin. Skin bhi ho sakta hai. Capsuloid spots. Medicine question. Maybe in NF1, 17 chromosome, 22 chromosome. Somebody was discussing in the histopathology in my group. पता नहीं दूसरे subjects का मेरे group में आप discuss क्यों करते रहते हो? Group को मैंने आज बंद कर दिया उसकी वजह से. मैंने लिखा उसमें. Should I close the group? आपको फर्क ही नहीं पड़ा. आप लिखी जा रहे हो, तो मैंने बंद ही कर दिया फिर. But abhi tak, after this test I will resume. So NF1, optic nerve glioma is the most common eye feature of NF1. In NF2, the most common eye feature is posterior subcapsular cataract. There is a pulsatile proptosis, yes, because there is a radiology question, sphenoid dysplasia. The brain herniates and pressed onto the eyeball, so there is a transmitted pulsatile proptosis in sphenoid dysplasia. There is nodules on the iris. Oh, I'm sorry. Most common eye manifestation of NF1 is not optic nerve glioma, is least nodules. That is the most common eye manifestation of NF1. There is a controversy. Some books write optic nerve glioma, but NF1 most common eye manifestation is least nodules. Most common eye manifestation of NF2 is posterior subcapsular cataract. Now, axial proptosis, yes, because of optic nerve glioma. This can also be seen in NF people. Plexiform neurofibroma can be there. There is a mechanical ptosis. But this diffuse retinal hemangioma, let us see who can answer this. Let us see who can answer this live. Diffuse retinal hemangioma, it's a difficult question, can be seen in which condition in ophthalmology or a systemic condition? I'll give you a hint. If I give you a hint, then you will answer. Port wine stain. Sturge-Weber syndrome. Sturge-Weber syndrome has diffuse choroidal retinal hemangioma, that is port wine stain. Okay, that is not seen in neurofibromatosis. Alright. Chalo, good answer. 8th. A 7-year-old boy was brought to the clinic with acute painful proptosis. You should know a child with proptosis. I give a chart in the class. It's a very, very important question. Acute painful proptosis in the right eye, visual acuity was normal and normal anterior and posterior segment. Means something is not inside the eye. If something is not inside the eye, you should rule out retinoblastoma. Retinoblastoma is an intraocular tumor. There should be something inside the eye. It's a retinoblast, primitive retina tumor. So that is ruled out. Now, which is not considered, that is the answer. Retinoblastoma should not be considered because it should be an orbit tumor. Rhabdomyosarcoma is the most common primary malignant tumor of the child. That is usually the first differential over here, mostly in boys, 7-year-old boys. If I say which is the first differential, answer is rhabdomyosarcoma. Which is not a differential, answer is retinoblastoma. Neuroblastoma, ruptured dermoid also can have acute painful proptosis. Even ruptured dermoid, I am not saying dermoid. Ruptured dermoid, that's why it can also have acute painful, but eye is normal. These A, C, D are intraorbital tumors, okay, not in the eyeball. So eyeball can be normal, but retinoblastoma, the eyeball is not normal. That is the answer of this question. I hope you're getting the point. And retinoblastoma, Chitra, a student, very good student, has answered very beautifully in my group what is the staging and treatment of retinoblastoma, and a student of ours today, and I have just copied and pasted her message. That was a very good answer of management of retinoblastoma depending on the stage and group of retinoblastoma. Okay, the 9th question. All of the signs of thyroid, say thyroid is the most common cause of unilateral bilateral proptosis. That's why the word exophthalmos is reserved for thyroid. And this is the eyeball, this is the eyelid. If the eyeball is coming out, eyelids are retracted. Now there's a controversy in surgery. They say most common sign, I don't know what, but most common sign is eyelid retraction. That is Derilimpe's eyelid retraction. There is decreased blink rate, not increased blink rate. Ophthalmoplegia, yes, because eyeball, the muscles are involved. If the muscles are involved, rectus more than oblique. I am so lazy. Inferior rectus is the most common muscle involved, so its difficulty, restriction of eye movements can be there. That is ophthalmoplegia. And yes, there is an increased IOP on up gaze because IR is the most common muscle involved. If that is fibrosed, if the patient looks up, the pressure can increase. So that is also true. But not increased, but decreased blink rate is seen in thyroid eye disease patients. Thyroid eye disease is a very, very important question of PG exam. You should know this. And what else I can say on thyroid eye disease? That's why the word exophthalmos is used for thyroid eye disease. The von Graff's Laidlack sign is there. And yeah, radiology question. Which part of the muscle is involved? Belly or tendon or both? Only belly of the muscle is involved. That's why I don't know. I'm correct or not. It's a Coca-Cola bottle sign or what? I don't know. But only belly is involved. Tendons are spared. In which condition? Extra question. Not ophthalmological, mostly radiologically. In which condition relate similar to thyroid? Belly and tendon both are involved. Radiologically. Who can answer this question? Answer is pseudotumor. That is idiopathic orbital inflammatory disease. A difficult question. Pseudotumor should be the answer of that. And the last question is age is not the criteria, which is odd one out. Now it's a very easy question. You should know some ages. Sometimes ages also you can tell. Thyroid eye disease is seen in middle-aged people, female more than males. Cavernous hemangiomas is the most common benign intraorbital tumor in adults. So that is in adults. Also more common in females. Optic nerve meningioma is also more common in female middle-aged adults. Optic nerve glioma is seen in the NF1 more than 2. That is seen in girls. 5 to 10-year-old females most common. That's why if age is considered, optic glioma should be the odd one out over here. That is the 10 questions. I have done correctly.